Hi, my name's Jamie with Qualicare KC. We're a home care company here in the local area. We've had a lot of questions since my sister and I have started this venture regarding the differences between home care, home health, and hospice. So I have Andrea here from St Croix Hospice, and we're going to just do a light educational, give you some resources to have a better understanding of how all of those teams work together and how you can help guide yourself through any of this future processes, whether it's now or whether you're in it later. So we'll just kind of jump right in. Plan ahead. That is huge. Educate yourself on how the processes work with hospice, how different things work with home health and home care as well. So that's a big deal. It's just getting yourself familiar with home care when you say, and all the different aspects of taking the time to understand. Waiting for crisis creates a much bigger issue with the crisis. Everybody's running hot, everybody's scared. So not waiting for this moment, even though it is scary to deal with these H words. That's what we call them. I mean,
right. And I think the thing that's important to remember too is that a lot of people think that this isn't something that they need to think about. This isn't affecting them right now. And ultimately, at some point in time in everyone's life, either you're going to be faced with health issues, your parents, your siblings, your neighbor, someone that you go to church with, everyone in your circle at some point in time is going to need someone who has been educated in some fashion about what opportunities are available for them for help out there. So whether you're specifically dealing with this right now or not, it's important to know this information so that when that person in your circle is experiencing some kind of health issue with one of their loved ones, you're able to say, you know what? I know somebody you can reach out to that can help you. So that's why we're really here today, to give that information and education so that when the time comes, you have some more kind of ammunition in your pocket to be able to help your friends and family.
And yeah, to take some of the fear away. Your fear can be powerful for yourself, I think, but knowledge is power. That's your power when you're going through crisis. Having the knowledge is what helps you get through some of this. So explaining what we'll call the H's. So defining the differences, how we work together, the misconceptions.
There's a lot of them, especially with hospice.
Yeah, nobody likes to hear that word. Non-skilled versus skilled. And then again, we're just going to pound it into your head. Don't wait for crisis. So home care being Nikki and I's kind of realm of where we are is a range of services that are in home to help with, that could range anywhere from a family caregiver, regular caregivers, personal care aides, CNAs, like bathing and dressing, meal prep. I think the biggest difference for me when it comes to home care, the easiest way, is home care can take care of the whole household. Short of cleaning your gutters, and we're not shoveling the driveway, sorry.
Just putting that out there.
Right. Yeah. Just yeah. And then, but we partner with, we can grocery, errands, doctor's appointments, and all of those types of things can help make the house stay functional. Whereas home health and hospice are more about taking care of the physical body. And then I'll let Andrea go more into the emotional sides and different tools and things that you all have for hospice. But in regards to home health, that's going to be your PT, your OT, your speech therapy. Yes, you're going to have some nursing come to the house, but they're not going to do your laundry for you, and they're not going to take the trash out. Although some might take the trash out real quick. They're not going to do the laundry. And that's kind of the biggest difference, is the physical body versus the whole household.
Right. And traditionally with home health, it's going to be something that's prescribed when someone has let's say had a hospital stay and they need to, they're going back home, but they need to be focusing on trying to get better, get stronger, those kind of things. Let's say, somebody had a fracture and they're ready to go home, but they still need more intensive therapy and those kind of things. That's where your home health is really going to come into play. But again, like Jamie said, they're not there taking care of the whole household.
Right. Letting dogs out or
Mhm.
doing different things, and we work together with them with the appointments. You have to have a physician's order for home health.
Yes.
You do not have to have a physician's order for home care
Mhm.
or in-home care, whatever. You just start and stop that. Every agency has their different policies when it comes to that, and we're not going to get into any of those policies. So more specific to hospice, my favorite term, learning from Andrea, is long-term hospice. I'm
Mhm.
finding that clients, when we mention the H word, that if I put long-term in front of it,
Mhm.
they're not instantly shutting me down. Me personally, I had an experience with it that a lot of people do know about, and we couldn't say the word.
Mhm.
And if I had known then what I know now, I would have known that there were certain things that we could have taken advantage of
Mhm.
that would have maybe helped.
Right.
And so I'll let you go into kind of the hospice side.
Right. And I'm glad that you bring that up because it really is most of the time until someone has had a personal experience with hospice or has been through an educational series like this, they always have a misconception about hospice. I would say pretty much 100% of the people who aren't familiar with hospice have a misconception about hospice. So that's something that we are continually educating, our physicians, our providers, but also just as importantly is just the community at large, that, you don't need to wait until your doctor brings up hospice. Get educated on it, what it means and what it doesn't mean. So when you bring up long-term hospice, I do like that terminology because, for instance, I was speaking with a family member the other day, and they said, well, I don't think they're ready for hospice yet. And having conversations with them, they were referring to something, an experience they had in the past where it was with a hospice house. So that person was, for lack of a better term, essentially actively dying and had probably a week or less of life left. And that's what that person thought hospice was. And so that's one of the misconceptions that we deal with a lot is that when people hear that word hospice, they think about it like it used to be back in, perhaps the earlier years in their generation where hospice truly did come in and, the last week or two of life, people were typically bedbound, they were having pain and needing, morphine, those kind of things. So that's what people still equate hospice as being today. So getting that education that, absolutely we're going to help those people who have, days to weeks left, of course. But if you can utilize that hospice benefit when you're medically appropriate under the guidelines that Medicare puts out for us, then you're going to get so much more advantage out of using those services. So when you hear this and people in your circle maybe say, oh my goodness, my grandmother's, this is the third time she's been to the hospital and she's tried rehab a couple times and she's just getting so tired. It may be that nobody has brought up the possibility of utilizing hospice and that their grandmother may be appropriate for that level of care. And so being educated just in the community to say, hey, listen, hospice doesn't have to mean what it used to mean. Here's a girl you can talk to and get that information so that you guys can get help. One of the misconceptions that we deal with too is that if you come onto hospice, that it just means that you are giving up. You're giving up on everything. When in reality, yes, it's just kind of switching your focus of your healthcare treatment options from aggressive treatment, hospitalizations, diagnostic imaging, all of these treatment-based things for improvement, and switching your focus to quality of life, comfort, being able to do the things that you want to do with whatever amount of time that you have left, because nobody really has a crystal ball for that. So the great thing about hospice is that it is covered under most all insurance policies now. It's covered 100% under Medicare Part A. It's covered under Medicaid. It now has policies under long-term care insurance. So, never let hospice cost be a barrier to you reaching out to get information about that. We're about providing comfort. Our clinical nurses are specially trained in pain management. But in addition to meeting those physical needs, we also are there to meet those emotional and spiritual needs for not only our patients, but their families. Because when somebody is on hospice care, it's not just the person that's going through this, and that it's the family that's going through this also. So we're here to support not just the patient that's on service, but their family member as well. We help coordinate their medical needs, medications. Hospice even covers the cost of your medical equipment, things like a hospital bed, oxygen, wheelchair, walker, shower bench, bedside table, any of those kind of things that we can bring into your home and make your caregiving for your family or the people, with private duty coming in, to help make that easier, is what we can help provide for them. It even covers the cost of things like incontinence supplies. So if the person is wearing pull-ups or briefs, hospice picks up the cost and supplies that for you. And the thing about hospice care, one of the misconceptions that we get is that people think I have to go somewhere to be on hospice. So there are freestanding hospice facilities like the hospice house that I mentioned earlier, but that's really just for a small majority of people who have some kind of crisis that needs symptom management and who are typically at the very, very, very end stage of their disease process there. So we go wherever your home is. If you're living in a residential home, we come there. If you're in a nursing facility, we go there. Assisted living, we go there. So we stay with you wherever you're at. And if you need to change your level of care, then we stay with you through that process as well. And our goal is always about just enhancing someone's quality of life. And that quality of life is going to look different to everybody. I've worked with some people who just want to have enough energy to get in the car and go for a drive around town or do things that we take for granted, like going to the grocery store. So if we can help, especially in partnership with home care, be able to help people do those things, then that's what it's all about. And that can be a misconception that we deal with too, because typically with home health, someone needs to be essentially homebound. With hospice, if you want to get out, we want to help you get out. We've had patients before that just wanted to go fishing one more time. So we worked with an organization and our nurses went with them and were able to help them go fishing again. So it's really about just switching your focus from aggressive measures, hospitalization, anything that can possibly be done, to let's focus on our comfort. Let's just let whatever's happening naturally with our body happen and have this group of medical professionals there to help support us through that.
Well, I think it's bringing the doctors to the home. I mean, the energy, like you've said to me, the bucket of energy that you take, and that it costs somebody to go to the doctor's office when you're literally just going to fill a script that you know is basic and this and that. You can take some of those things off your list.
Absolutely.
And in working with private duty like us, yes, we are there to help take to doctor's appointments, but we are also there to go fishing and go to the library, go to have coffee with a friend. And if you want to have a coffee with a friend and we go off to the corner, we hang out with you at the same time. So there's a lot of different ways. Bottom line, all three of these are a total of continuum care. They all work hand in hand, and we kind of have, I kind of thought of some examples of some different ways. We kind of already skipped ahead.
Right, yeah. Once you get me talking about hospice, I'm very passionate about it.
Good. So again, just to then when we can, this will be in the slides. You guys will be able to have this as we talked about this. This isn't a days and a weeks thing. This isn't a dying, it's happening.
It doesn't have to be. So
No.
sometimes it is, but nothing breaks my heart more than, getting a call from a family member or a patient themselves that says, hey, they're kind of struggling at home. And, we get out there and we recognize, almost immediately that this person could have been getting help through hospice for months. for months, and they've been at home struggling, just trying to care for themselves, and that's
And
why.
buying medical equipment
Uh-huh.
on their
Mhm.
own
Mhm.
when if they're just managing the illness, whether that's congestive heart failure,
Mhm.
Parkinson's, Alzheimer's, dementia, cancer,
Mhm.
all of those diseases. But no, hospice does not speed it up.
Mhm.
It does not, that is a big thing.
Mhm.
I think it can enhance what you're already doing. It's just a way of switching our brain to say, that this isn't, that's not what it is. And you hear all the old stories. That's why
Mhm.
we call the old stories. And some of them are current
Right.
stories. A lot of times if you're hearing that person passed away a week later, it might have been once again because they waited so
Exactly.
long. We had a client that we literally brought Andrea with us. Sorry. Andrea with us to it because we knew that they had waited so long and they did not have the funds to afford complete private care.
Mhm.
We know that we can allocate some of those funds with bath aids and things like
Mhm.
that. Therefore, they're not paying us hourly. We can do other things.
Mhm.
So again, that's kind of how we work together. We're going to coordinate the plans between all of these, whether it's home care and home health or home care and hospice. We can all collaborate to avoid duplication or gaps
Mhm.
in services. And that is, it's services and all this care is a giant puzzle.
Exactly.
And it's just one piece,
Mhm.
one piece,
Mhm.
one piece, the doctors, the physicians,
Mhm.
the family,
Right.
and bringing that all together to create a continuity of just, I don't know, I can't
Putting
even
all the
basic-
pieces of the puzzle
Yeah,
together,
it's
and it's
just-
gonna look different for every person, and that puzzle can change.
It does, and it can change on a
Mhm.
dime.
Absolutely.
But having the education can help you be able to cope and manage some of that together. So an example of kind of how home care can come in is let's say that somebody's hiring us private duty for 4 hours and Jane has a PT appointment. Home health is coming. That's who's doing the PT. They're only there less than an hour, maybe, maybe an hour max. So yes, that's gonna give, they're not gonna not take her to the bathroom, or they're not gonna not do something very specific to her. But if, let's say, Jane's daughter couldn't be with her for that appointment because she had to get back to work because she'd already taken so much time off work when mom was in the hospital. So we can be there through home care where we can gather that information and relay it to the family. We have a family portal. We can even take pictures and relay that information so that it's kind of like you are there, and make sure that continuum of care. When hospice is brought in, it may look like hospice isn't setting vigil from day one,
Right.
and a lot of hospice companies are not ever setting vigil and 24/7 hospice anymore. So sometimes we fill in those gaps between when family can be there. You'd reference the hospice homes. That a hospice home might have to be used for somebody who doesn't have a home,
Right.
where family can care for them.
Mhm.
Like, mom, this is mom's too, can't be alone, and we can't be at her house, and we don't have the room for her at our house, is maybe why somebody would
Right.
also
And
go.
for the most part, I would say honestly, like 99% of the time, people want to be in their home. They don't want to have to go somewhere else.
Right.
There have been some situations where maybe it was going to be too difficult for the family to have that person pass away there. And so we would coordinate transfer to a hospice house for them. So again, each situation is going to be different, and each situation can change from day to day, depending on what's going on. And that's what I love about home care, is that you guys are working with the families, with the individuals, to really meet their needs, even as they change.
Right.
Mhm.
Yeah. And a lot of times if we are there, we have had a family where we're the ones telling hospice, this is how they were the other night. This is how they, this is they're going to the bathroom a lot. We may suspect a UTI, and your nurses can come in and the doctors can prescribe medications, but having that day to day. Now, if home care isn't, because it is private duty, in most cases, you know, then the family and hospice, everybody tries to do the best that they can.
Absolutely.
But everybody's stretched, you know, a little bit thin.
And that's where I think too, kind of bringing it back to knowing what services are available to you and looking into those as soon as possible. Because anybody who's been a full-time caregiver knows how stressful that can be. Absolute best of intentions. You want to take care of your loved one. You want to do all of these things for them. But people sometimes don't understand how difficult it is and how taxing it is on them. I've seen it more times than I would have liked to, that, you know, a husband is caring for his wife. He's so doting and taking care of her, but he's not taking care of himself.
Mhm.
And he's put so much energy into caring for his wife that he missed his appointments and these kind of things. Next thing we know, husband's in the hospital. And
And
now
we-
it's crisis mode.
We
because
literally just had that
yes,
happen.
yes. And so understanding that even though you want to be able to do all these things, it's okay to say, I can't do all of these things. It really is okay to give yourself permission to know that I can do some things, but I may not be able to do all things.
Yeah, it makes a big difference, and our goal, I think, would just be to all around provide some level of peace of mind,
Mhm.
resource, or you know, in a lot of ways, and I don't ever want to compare seniors to children. But I think this is the only analogy. A lot of times the person that we're caring for tells us things that they
Mhm.
won't tell you.
Mhm.
And, but it's kind of like when your kid went to school and they mind the teacher and you're like, was that really my kid? Like, they're behaving, you know, because maybe they don't behave well at home.
Mhm.
The relationship and the things that they confide in us, sometimes makes us feel, like we're like this spy or a tattletale or something. And we're like, gosh, should we tell? Do we say?
Right.
But I think it having that outside opinion, unbiased, and having that person, the goal is to empower the person who's going through
Mhm.
this, because they're the ones going through the physical side of things, and giving them that voice.
Absolutely.
And
That independence for as long as is absolutely possible.
yeah. Just in a short way, I wanted to do a little vocabulary lesson, in that the in-home care can focus on your ADLs, and those are your activities of daily living. And then your IADLs being your instrumental days of living or daily living. So, and skilled and non-skilled, the easiest way between home care and I don't, and how you can say how it is on your end, we can hand the meds, open the med bottle, help them with their hand to that, but technically we can't fill the pill bottle.
Mhm.
Like, we can't fill the boxes. We can hold the injection, help them get it to. So
Mhm.
there's this gray area between non-skilled and managing all of that, whereas nursing can come in and we can do vitals, nursing can do vitals, but it's not considered a skilled service from a non-skilled home care situation. But with hospice, and
You
depending
can
on
do all those
yeah,
things.
so depending on, am I right? That some hospice companies have a doctor or physician on call, or do all of them?
They, under the Medicare guidelines, they should always have a physician
All of
on
them.
call, a hospice
Okay.
medical director. So, St. Croix has multiple, medical directors. Our chief medical director is, actually Dr. Andrew Mayo from the Mayo Clinic family.
Oh, okay.
So, but, we've got a
Yeah.
local one, we've got a local one in Harrisonville. We've got a statewide one for Missouri, because, we've got one in Kansas. St. Croix has multiple locations across, the United States. Yeah, and I'm out of the Harrisonville and Independence branch, but we've got them kind of all over the place. So don't let wherever your location is be a deterrent either. But yeah, so
Yeah.
there's always the ability for us to be able to get a hold of a physician physician, we like to work with your primary care physician, because oftentimes you've been seeing your primary care physician for years and years. So that's another misconception
That's
that
what I
we
was gonna
hear.
say, that's
Mhm.
another thing that people think all, so let's be specific and we may be jumping ahead and around, I'm just.
That's
kind
what
of
we do.
flipping. I know, it's in our brains and
Mm-hmm.
we may have put it on here so that y'all have it, but, we've kind of already talked about some of this stuff, but, when it comes to the physicians or, again, kind of decision making, planning ahead, access to the information, the there are different hospice companies where they will make you shut down, correct? From all enrolled physicians.
That's what I've
Those
been
are-
told, yeah.
Those are questions that you need to ask.
Mhm.
If you are wanting, let's say grandpa really loves his primary care physician, and if you take that away from him, he's gonna shut down because he's
Mhm.
gonna feel like you're removing
Mhm.
this thing that he loves to go see her or
Exactly.
him. And
We had that come up, not too terribly long ago, where it was like, for him and that family, it was going to be like a deal breaker essentially if he wasn't able to continue to go. And so when I explained to them, like, yeah, absolutely, you can still go see your physician. Where people have to understand is that once you're signing up for hospice, you really are saying that, you know what, I'm at the point where I don't want a bunch of aggressive measures done, like we talked about earlier. I want to focus on comfort care or my quality of life. So we're fine with you going to the doctor and seeing your doctor and having a visit. It's just making sure that they're not ordering an MRI and referring you to go get all of these aggressive measures done.
experimental treatments,
Exactly.
chemotherapy, Parkinson's have different experimental
Mhm.
medications and things like that. That means you're actively still trying to uh fight and reverse,
Seek more curative,
right.
seek more
And-
curative measures.
And yes, quality of life is the word that honestly I absolutely hated when I heard it. But it makes more sense. So I change it in my brain to say it so you can have fun.
Mhm.
You spent your whole life working
Mhm.
or doing this or doing that. Let's just hang out
Mhm.
and have fun. And
Mhm.
that in itself is quality of life. That in
Absolutely.
itself of being able to do those things is quality of life, for sure. So there's really no other word for it, even
Mhm.
though I didn't like hearing it.
It's
But
hard because you don't really know until you're in the situation, like, what do you mean by quality of life? So
Yeah.
being able to, kind of explain to people. And at the end of the day, everybody gets to make their own decisions. Everybody gets to be in charge of, what they want their healthcare future and their life to look like. But it's so important to have that information and to have accurate information so you can make the best decision for you and for your loved ones.
right, kind of like I said here, knowledge is your
Mhm.
superpower. That is what will help get you through some of these hard times. And if you're a person that's maybe watching this and you have been diagnosed with something, families saying do this, do that, and treat, and maybe you don't want to do it. This is also to empower those people that are trying to make decisions for themselves through their own hard time. And we want those persons to still have that power and giving you even that piece of knowledge and a resource and a way to reach out and get in contact with somebody so that you can help with these emotional preparations. Some people take a diagnosis like Alzheimer's with, I got to get ahead of everything and I got to make sure all my ducks are in a row. And some people just want to, like, it
Kind of be in
didn't
denial.
happen. And
Mhm.
so then it's a good support team on the back end of that. So I think, yeah, the key takeaways is don't ever be afraid to ask a question to a nurse, a physician. I understand the white coat and syndrome, but I kind of don't because I don't have a problem asking the question. They're not going to do anything to you and they're not going to treat your loved one any different. If they do, or you even feel that, then you might be in the wrong place to begin with. Bedside manner from all persons in this field is a must.
Mhm.
And you
Absolutely.
should demand it.
And especially, with hospice specifically, like we've talked about throughout this is that there are a lot of misconceptions out there, and it's misconceptions within the medical community itself also. And so there are some physicians who are wonderful that when their patients come in to see them and they've been noticing these declines, that they have the conversations with them, help take the fear out of the word hospice and educate them. But there's others who maybe don't understand it, or who haven't been in the practice of recognizing when it's the right time to bring those conversations up. So that's why it's so important to know that if you're interested in hospice, yes, we have to have a doctor's order to initiate service, but you do not have to wait for your doctor to bring it up to start looking into that, because I have literally had people reach out to me for their loved one who had been seeing their specialist every 6 months for whatever kind of end stage diagnosis. It was never brought up. It was never mentioned. The family reached out to us. We in turn got in touch with the physician's office, got the order from them, got the medical records, did everything we needed to do on our end to meet those Medicare regulations, had our nurse go out there and evaluate this person who was abundantly appropriate, that passed away within 24 to 48 hours. And hospice had never been mentioned, even though they had this life-limiting progressive illness. So just know that empower yourself to ask the questions, reach out. I talk to people a lot who aren't necessarily at the point that they're ready for hospice, but the medical community can be very overwhelming and you don't know which way to go or the questions to ask. And so I know, for myself, and I'm sure for you too, like we want to be resources for you, that if you're going through these things and you just don't know where to turn, or if they're, medically appropriate for hospice, or if they're, appropriate and need that home care, but you have questions, don't hesitate to ask. That's what we're here for.
Yeah. Nikki and I are always gathering information, and we're we want to be that resource, and and pass it on to hospice. That's why we bring Andrea in, and because they've already helped with multiple patients, and she's opened my eyes to a lot of different ways of how to share with this. But I actually have a question that I know a lot of people have had. I was hung up on the word palliative. I liked it because it didn't mean the end. But then now that I'm kind of in the thick of different things, palliative, give an explanation of.
It's a great question. It's a great question, because we'll get calls in our office that say, hey, do you guys provide palliative care? And my response to that is, tell me what you mean by palliative care. So palliative care, just by definition, means relief of symptoms, of symptom management. So the difference between palliative care and hospice should really boil down to, are you at the stage where you want to seek aggressive treatment for your illness, or are you past that point where either you don't want to continue aggressive treatment, or there really isn't any other aggressive treatment to offer? So because hospice, of course, what we do as well is symptom management. So part of what hospice does is the palliation of symptoms. However, if we'll use the example, let's say somebody has lung cancer and they're still getting chemotherapy, they're still getting radiation, they're still, fighting this disease, but they have pain, they have shortness of breath. That's the absolute right time to be using palliative care, because palliative care is essentially going to be, my understanding, 1 to 2 visits a month from nursing. It doesn't provide all of the other things that hospice care does. Oftentimes palliative care is brought up kind of like you said in your experience. It sounds a lot nicer. It's not that
It's not
H
a
word.
word.
But you're not getting the services that you could and the support you could if you've already reached the point where there's nothing else to be done and you want to focus on your comfort. Palliative care should not be the option that you're using. If it is, it's probably because you have misconceptions about hospice. Because hospice does not have to come in. We are very much, especially at St. Croix, about making it our care plan individual to each patient. So maybe sometimes when people are first starting services, they don't want a home health aide. They don't want to see the chaplain. They don't want the massage therapy that we offer. Maybe they just want a nurse coming in once a week. And that's what we'll do. So people shouldn't be held up on the definition or the word hospice. But going back to like the phone calls I'll get in the office that say, do you guys provide palliative care? I was just at the doctor's office with my dad and they said, we need palliative care. I said, well, tell me what you mean by palliative care. So, well, my dad has congestive heart failure and he's in and out of the hospital a lot because his legs get swollen and you get short of breath and there's just nothing else that they can do and he's really sick and tired of having to go to the hospital all the time. And so the doctor said we should look into palliative care.
Yeah.
That should be hospice because they said there's nothing else that can be done. So we're not seeking aggressive treatment for this. The patient doesn't want to have to keep going back and forth to the hospital. They're kind of in the mindset, at least by the initial conversation, that they want to just focus on their comfort and their quality of life and have their health care brought to them. Then as I continue the conversation with the person on the phone, they're like, oh, well, I didn't know that about hospice. Like I thought my dad had to be like bed bound.
Yeah.
He still wants to get out and go. And it's like, oh, great. We'll help him be able to do that while managing his symptoms.
And not taking more money out of your pocket because you're going to the store and you're trying to figure out who has a hospital bed and you're trying to rent one and you're trying to go get this or go get that. Having said that, between palliative and hospice, by all means, if someone is battling cancer or battling the beginning stages of whatever diagnosis, by all means, fight that disease and let them keep that fight, but don't wait for palliative care. Just go ahead and get it going.
Right.
Because then you can do things like potential fluids at home and management and things, and it doesn't mean you're stopping all of the other treatments. But because palliative is so close to the next word being hospice, palliative can even be scary. So you wait for that. And when really it can be started much sooner. So
Absolutely.
it's important for people to know about palliative when somebody is getting ready to do that battle. Do that battle with palliative care.
Every resource that you can get available to help you through this. Absolutely.
Yes.
Absolutely. It's just at the point in time when there's nothing else that can be done to treat that disease, or you've decided you no longer want to treat that disease and you meet the requirements that Medicare puts out for us, then hospice is going to offer you so many more benefits than just palliative care. Oh, great question.
Well, we already did that. So, well, thank you guys. We hope that we helped, and you guys have a good rest of the year. Have a good one.
Thank you.
Bye.
Bye.